All right, good morning. So we'll start with a case, 6-year-old female who says post a right total hip revision, in this case to a constrained liner, as you can see, but she unfortunately presented with pain, recurrent pain and instability. As you can see here, she came out. Unfortunately, she failed all treatment prior to this and underwent a cup revision with a dual mobility implant, and she had no pain and stability at 3-year follow-up. So we're kind of try to introduce the biomechanics, why we think about dual mobility, and kind of what the options are now. So a little bit of background: total hip arthroplasty is considered one of the most successful surgical procedures. However, the annual performance is projected to reach over 500,000 by 2030. Unfortunately, instability is still a concern, and it's one of the most common complications in total hip. The estimates of this vary widely, but in general, kind of the accepted numbers are 2% in primary and then 5 to 10, although I've seen up to 28% reported in revision surgery. Most dislocations are isolated and they can be treated conservatively. Unfortunately, some patients will go on to chronic instability and ultimately require revision, and this actually accounts for 22.5% of all revisions. So surgical treatment of stability consists of revision of malpositioned components if these are identified, tissue reinforcement if you have breakdown of the adductors, or depending on the approach you do, you can have dysfunction based on that. Larger femoral heads, so greater than 36 millimeter heads, will increase the stability and improve the head-neck ratio and increase the jump distance required to dislocate. Constrained liners, as we saw in the previous patient or in the case, they essentially lock the femoral head into the cup and allow stability and potentially allows increased stability without revision of a well-fixed cup. And then there's the dual mobility, also known as, you may see in the literature, the tripolar articulations. So what does this mean? So the biomechanics of the dual mobility component are two distinct articulations. The first is classically that we think of between the femoral head and the polyliner, which is the primary, and that's where the majority of the arc of motion comes from. And then this is increased by range of motion between articulation between the liner and the acetabular shell. So what this does is it can increase the range of motion compared to the conventional and also constrained components, and then compared to larger head sizes that are used traditionally, if you're going to revise, it also increases the head to neck ratio and a larger effective head size without losing poly thickness. So this is a study by Wynn in 2007, and they looked at range of motion comparing, and I'll point out that these are 22 and 28 millimeter heads, so they're on kind of the smaller side than some of the more modern like primary implants, but they looked at conventional versus the dual mobility, and they found that there was significantly greater range of motion in the dual mobility implants compared to the conventional implants in all planes. They were looking primarily, the changes were in impingement in the articulations of the component, so they didn't really include the bony impingement that would have occurred regardless based on the patient's anatomy. So dual mobility can be used in primary or revision arthroplasty, and dual mobility in the US is relatively new, but it's actually been used in Europe for over 35 years, and that's where most of the studies and long-term outcomes are from. So one of the main cups is this one on the top here, the Nove 1 by Omnisurf. They say that they were the inventor of dual mobility, and it has the most studies. Just as an example, I found 5 that have about an average of 15-year follow-up. The survivorship varied. It was between 81 and 96, and they report 0 to 1 dislocations. And then Boyer, probably the longest that I found was 22 years, and they found a survivorship of 74%, but no dislocations during that time. But it really depends on what study you look at. So, for example, this is a study by Philippot that they looked at 384 at 15 years, and they used that Nove 1 cup, and they found a survivorship of over 96%, and an interprosthetic dislocation rate, which I'll touch on what that means in a little bit, of 3.6%. In terms of revision, in general, the components studied are similar. So less follow-up overall and a little bit higher dislocation rate, 1.1 to 5.5. Their survivorship remained quite good, though, even in these revision surgeries. And overall, I would say that there were better outcomes than compared to revision with conventional implants, as the dislocation rate, as I mentioned, ranges from 5 to 10, up higher than that, depending on kind of, surgical technique, but also the indication for the revision makes a big difference. An example, again, this is Philippot. He did 163 revisions with the same cup. Mean follow-up of over 5 years. Mean survival, or 7-year survival, was 96%, and the dislocation rate was 3.7. I will say that if you break this down for dislocation/instability of the revision cup, it was dependent on the indication. So if it was done for aseptic loosening, it hovered around 3%. But if the revision was done for an infection, for example, it shot up to 9%. So you can imagine that makes a big difference. And then after just recurrent instability in general, the dislocation rate after revision was actually 0. So that's great. That's what is being done across the pond. But what about here? What are our options here? So dual mobility options in the United States you basically have 3. So you have the Biomed active articulation, you have the Smith & Nephew polar cup, and you have the Stryker, their version. And then the Biomed and the Stryker both have modular versions. Modular dual mobility is the same idea, except that you add an additional component. So there's a modular portion between the cup and the metal liner. And what this does is it allows for screw fixation. So you get better fixation theoretically, and you can also get better cup control because you can actually use a joystick with it. It's good for revision. I put instability metal on metal here, but also aseptic loosening as well, because it allows for retention of a well-fixed and position, presumably component, and the caveat is it has to be compatible, obviously. And one concern here, as you can imagine, with all the metal on metal issues, we worry about classically between the cup and the head, and then we're now worried about trunniinosis. Now, if you're thinking about MDM, you can imagine that there's the potential for metallosis between the liner and the cup, and that's a concern. This is a study done here. It's in the upcoming issue of DOJ, where they looked at short-term follow-up of 82 revisions with MDM cup, modular dual mobility. It was, again, short-term follow-up, the indications for aseptic loosening, infection, instability, and metallosis, and they had no early dislocation. So, again, it's short-term, but this is some of the best data we have right now currently, and we're actually trying to update that right now with at least 2-year follow-up on some of these patients. This was a study done looking primarily at the concern for the metal-on-metal issue. So 100 consecutive patients were looked at who underwent, and I would just point out these were primary total hips, not revisions, with a modular dual mobility cup with average follow-up of just over 2 years, and they basically followed their serum ions, their metal ions. And their cutoff for what they would consider a serum metallosis was 1.6 for cobalt, and they found 9 patients. 5 of these had other possible sources, so either they were revised for a previous metal-on-metal implant, or they had a total hip on the other side. And 3 patients had repeat elevated ions as they followed them out. An MRI was done on 1, which did show an acute local tissue reaction. That said, all of that aside, the Oxford scores and the symptoms were not affected by the ion levels, and no patient required revision total hip. The other thing that I would point out about this is they kind of buried it, but 99 out of 100 of these patients had a cobalt chrome head. So already there was some potential in there for the metal ions coming from trunniinosis, but that wasn't teased out. Another great indication, I didn't know about this was really surprising to me, but dual mobility in femoral neck fractures is actually a great indication. So just for starters, a meta-analysis showed that around 11%, there's an 11% dislocation rate of total hips done for femoral neck fractures. And so studies have been done comparing dual mobility versus conventional total hip. And so one study found a 14.3% dislocation rate at 1 year for conventional and no dislocations for a dual mobility. Another study at only 9 months, but still they found there was only a 1.4% dislocation rate using dual mobility. So again, there's not a ton of data, but it's pretty compelling, honestly. And I think it's something to consider if you're out and you're thinking about doing a total hip in a patient instead of a hemi for a femoral neck. One important consideration for dual mobility is this very unique complication, and it's called an intraprosthetic dislocation. And so basically the way this is done, the way that the implant is put in is that the head and liner articulation is press-fitted. And this is either done on the back table with one of these instruments, or you can see here that it's actually done in the patient in this case, or right before they reduce the liner into the cup. So you have this association, this kind of press fit between these. So the problem is that when these dislocate, you can end up with a dissociation between the head and the liner, and it can lead to a free-floating liner that's obviously not part of the construct anymore. So just in general, kind of looking through the studies that I referenced previously, there's about a 0, some people didn't have any, to a 5.3% IPD rate. And this is really concerning because identification on X-ray and review of the operative report is available is critical for appropriate treatment. So as these become more kind of popular and more common, these are things that as if we see someone come in with a dislocated total hip, it needs to be one of the things that goes through your head, especially if the implant doesn't quite look the same as what you're used to. So just as an example, this is one that actually presented here at Duke. Some of you may remember this case. So they presented dislocated. Unless you knew exactly what you were looking for, you may not recognize that this is a dual mobility implant. So this is post-reduction here on the right, and again, hindsight is 20/20 if you really know what you're looking for, but if you know, you might be able to make out a little halo at the top there post-reduction, and that's probably the liner that's been completely dissociated from the construct. This is another view. Again, you kind of have to know what you're looking for, but if you were really paying attention to it, you would note here that the head is eccentric in the cup, which suggests that the liner is no longer in place. So in summary, dual mobility provides 2 points of articulation, increasing range of motion compared to conventional implants, and it increases effective head size and jump distance without having to downsize the polyliner. There are historically good outcomes in primary and revision total hips with overall use increasing, especially in the United States. Currently, the data is limited on the implants available, the 3 that I discussed, and also consider it for total hips and femoral neck fractures. And then modular dual mobility may be a good option, especially in revision. There are good results in high-risk patients. The early outcomes and what we're finding as well, that there's pretty good results overall. However, there is the potential for metal-on-metal reaction. It's going to take a while, I think, to bore this out and to really know. And then intraprosthetic dislocation is a very real complication of dual mobility implants, and the identification is really critical, and it's something that we should all be thinking about. These are my references. I'd like to thank Dr. Wellman, Dr. Bolognese, Dr. Lekevich, and Drs. Moore and Dotar. And I'd like to open it for discussion. A couple of thoughts I had were just as you move forward, what are your indications for dual mobility? What do you think the role for primary dual mobility is? And then are you concerned about the metal-on-metal in terms of modular and what your indications for that? And then again, in terms of for the residents and as we move forward, folks that may not be going into joints, what is the best way to identify and treat this kind of growing issue of intraprosthetic dislocation?
Yeah, Grant, that was a great talk. You really sort of honed down on all the pros and cons very nicely there. Yeah, I think we all, or at least speaking for me and probably Bolo, we got a little intoxicated with these coming out of the gates. And, we're doing a lot of these metal-on-metal revisions and see some pretty beat-up soft tissues and concern about ability for the patient to form a decent pseudocapsule and concerns about stability. So we used a lot, but then obviously we started wondering about, are we actually getting enough cobalt chrome out of the hip? And I guess one question I'd throw your way is, why not just have a really big head and avoid the dual articulation? Really big ceramic head or something like that.
So the two thoughts that I had, one, I guess the poly materials are getting better and better, but you do have to, the bigger your head, the smaller, the thinner the poly is going to be, which can be a concern for wear and I would maybe catastrophic failure potentially. And then I think that in general, kind of the larger heads we use are in the 40 range, whereas with a dual mobility, the liner can get much bigger than that, like 48 millimeters, so that you essentially have a much bigger effective head size.
Yeah, I think, I'm most familiar with the Stryker system, but in general, it's the outer diameter of the poly, if you use a dual mobility, would be close to a centimeter bigger than it would be if you use their sort of biggest head. And as you get into bigger cups and revision scenarios, the difference becomes even greater. So, Bolo, what are your indications these days? You backed off a little bit.
Yeah, I think anybody that's a revision for instability, and I think it's an interesting thought for cases that you think are higher risk in the primary, which I have not done. So I've only at this point really utilized it for recurrent instability in a revision setting. I think probably one thing to think about that speaks to the use of it in the primary hip is probably as more of these systems become available, you might would think about putting in a cup as your primary cup, I guess, that has the ability to take one of these, one of the thin metal liners, so that if it did need to be converted, that may be an advantage to having that option. Because there's, I would think you're going to have more primary cup options from multiple companies that would eventually take some version of this. as a means to address instability. I think what what we Sam said, what we are nervous about is obviously you said it too. What's the issue? Now you've got still a metal interface, right? So we sort of learned our lesson, and maybe we did, on metal because, like you said, a lot of times we're using this for metal failures, but maybe we haven't eliminated the metal articulation or risk for long-term issues.
Tyler?
I'm trying to,
At this point, try to stay clear of it, especially board collection. I think it's controversial, and for the metal revisions that I did, I tried to get a 40 millimeter ceramic head. So far, not going to work well for me. Interesting, I think interesting what Paul alluded to is interesting indication. If you have an unstable hip and you put a cup in and you're worried about initial cup fixation, you can go and do mobility, let the cup grow in, and then if you have to come back, you can put a restraint in, versus going with a primary restraint and constraining, and then running the risk that they're going to rip that cup out. So maybe something to think about it.
I think it essentially comes down to, potential risk for instability versus potential risk of problems from this articulation, and it's a case-by-case basis. You just have to weigh it. Bill was pointed, I do revisions almost exclusively with the cup that will take this in case I want it. And so I think that's the sort of planning. I think one of the reasons we backed off early was that the cup that we were using most of this turned out to be kind of crappy. But that same company makes other cups that are good, so switched over and had better luck.
So why is it, when you talked about the original data on this, like the original data showed like none of them dislocated, then when other people looked at it, there was a higher dislocation rate. There's really no dislocations with this kind of a cup. It sounds like a great thing. Why do you think it is that there are such differences in the data? Why do some people get dislocations and other people didn't?
I think, and I didn't look into the specifics of like the breakdown of each study in terms of their patient population. I think that it's a a heterogeneous population such that there are different indications for revision. So you could have aseptic loosening and revise for that. That's a much lower risk to dislocate subsequently, I would think, than someone who had an infection, for example, and was revised for that reason, or who had metallosis and lost all of their soft tissue envelope, basically. So I think that may be where it comes from. And I would think that maybe there was a progression of dislocation because maybe people started to stretch the indication. First, they started off very conservatively, and then they said, well, let's try it for this and try it for this. And
I think one is that there's all different things that might cause a dislocation that may not necessarily be related to the prosthesis itself. I think everyone knows that, right? The second thing is that the numbers in the studies, there's studies of 300-400 people. If you're looking at something that happens 1%, that means you're going to get 3 or 4 in that series. And probably the numbers are way too small. By chance alone, you won't really see differences. So I would just say, I think my advice would be before everyone runs out and does these for primaries, wait for somebody else to have a big series to them because there may be some other kind of problems that occurs. Sam may know that at least when I was a resident at the Baptist, we used to put bipolars into regular arthroplasty cups for people who had revisions. And they kind of worked okay for a little while, but a lot of them need to come back and revise because the inner cup, the poly on the inside fell apart. But of course, that was a different kind of poly in a different year. It was 25 years ago. So you can't tell what's going to happen in several years. So don't run into this too quick. That's my advice.
I presented the patient safety conference on this last time, but I was thinking about this more. Why did they not put something radio opaque into the poly so that if it dissociates, you can see that a little bit easier?
I think that's an unanswered question. It's a great idea.
Probably because then you can see it.
Yeah.
It's there.
It might be really distressing to see a well-functioning one with crazy angles it's in every time you get an X-ray.
Yeah.
It's probably some crazy, flipped over and who knows what it's doing. I don't know. I think it's a good idea to put a couple little.
It could be at the base of the poly.
Yeah.